Good afternoon. So for this session, we're going to talk about the thyroid gland and its function. The thyroid gland is a gland. It's a glandular tissue that is located in the neck, particularly in the larynx. It is attached to the thyroid cartilage. That's why we call it the thyroid gland. The shape is like that of a butterfly. It has two lobes, which is separated by a connective tissue, which we call the isthmus. This gland is very important in metabolism and growth. Right, so there are two hormones produced by the thyroid gland, T3 and T4. T4 is also known as thyroxine or tetraiodothyronine, and T3 is also known as triiodotyrosine. So both of these are produced by the cells of the thyroid gland. Right, so the thyroid gland is around this area in the neck, in front, the anterior surface of the neck. It is palpable, so that means you can feel it. When you use your hand, you can feel the shape of the thyroid gland. I have mentioned that there are two hormones produced by the thyroid gland, T3 and T4. T3 and T4 are synthesized by the thyroid cells from iodine. This iodine combines with tyrosine, which is a non-essential amino acid, and once it combines, it can actually produce two different molecules, monoiodotyrosine and diiodotyrosine. So you have an idea how many iodine molecules are present in these molecules. Uh, Monoiodotyrosine, MIT, has one iodine, and DIT, or diiodotyrosine, has two iodine molecules. So in short, if we combine these two, 1 plus 2, monoiodotyrosine plus diiodotyrosine will form triiodotyrosine, which is T3. Right, so what about T4? T4 is formed when two molecules of diiodotyrosine are combined, so forming T4 or thyroxine. Um, these substances, these hormones are not soluble in plasma, so it requires the presence of thyroid binding globulin or TBG so that it can be transported to the plasma. Right, so and these two hormones can actually be converted into from one can revert from T3 to T4 and then T4 to T3. Right, so T3 is more potent. It has a more potent effect compared to T4. Right, so aside from T3 and T4, we have to know that the control of the production of the thyroid gland is under the pituitary, the anterior pituitary gland. It releases this hormone called TSH, or thyroid stimulating hormone, which is under the control of the hypothalamus by releasing the so-called TRH, or thyrotropin releasing hormone. Thyrotropin is another word for TSH. So, right. So T3 and T4, as we have mentioned, have an effect on metabolism, the metabolism. So how fast we utilize sources of energy. In doing so, we produce ATP and heat. Eh, and it also can manage the breakdown of glycogen and other sources of energy. Therefore, we can say that it is calorigenic. It produces calories or energy. Okay, in this slide, we can see the control and production of T3 and T4, and that is, we can say that it works by feedback mechanism, negative feedback mechanism. When the level of T3 and T4 is low in the blood, it will send signal to the pituitary gland, and the pituitary gland will be stimulated to produce TSH. However, before it can release the TSH, it needs permission from the hypothalamus. So when this TRH is released, TSH will also be released, and TSH will target the cells of the thyroid to produce these two hormones. The stored form of thyroid hormones is found in the so-called colloid. So this is like a circular or ovoidal structures within the thyroid gland that is lined with follicular cells. So there are follicles, and inside the follicles there is a colloid, and in this colloid we can find the stored form of these thyroid hormones, which we call thyroglobulin. So please do not be confused. This is thyroglobulin, not thyroid binding globulin or not thyroxine binding globulin. Right, so clinical significance. We can actually categorize the conditions under the thyroid gland as hyperthyroid or hypothyroid, and of course we also have some autoimmune diseases. Right, so the first condition is called hyperthyroidism. It's very easy to remember. When it is hyperthyroid, we produce a lot of T3 and T4. So the total T3 and T4 is high, and because it is high, the TSH production is low. Why is it like that? Because of the feedback mechanism. In negative feedback mechanism, when one is high, when the stimulus is high, the result is low, right? So what will happen when there is too much T3 and T4? Remember, it has something to do with um, metabolism. So in this case, there will be increased heart rate and metabolism. But aside from that, there will also be um, exophthalmos, or it's like the eyes appear to be bulging, and it has something to do with the antibodies, anti-thyroid antibodies that can attack the muscles of the eyes. Right, so there are many other symptoms. For example, if you try to raise your hand, you cannot really keep it at that position. Right, so, and also you feel warm all the time. Even if it's already very cold, you still feel warm. Right, and the person who suffers from this condition would normally be having low weight. That is because of too much energy is being consumed, so during metabolism. Right, so if it is the other organs, can be the pituitary or the hypothalamus that is affected, causing the production of T3 and T4 to be very high, we call it secondary hyperthyroidism. So remember, the difference between primary and secondary disease is that if it's another organ that is affected and yet it's causing the disease, then that is a secondary condition or secondary disease. All right, so the second condition is called hypothyroidism. So this is the opposite of hyperthyroidism. The amount of T3 and T4 is low and TSH level is high. But even if there is high amount of TSH, the result is still the level of the hormones remain low. Right, so the symptoms are the opposite. So people with hypothyroidism, their heart rate is slow, and the metabolic rate is also slow. Right, it can also lead to mental retardation or even failure to thrive in children. So that means they cannot live long. right? And this mental retardation has something to do with the amount of iodine in the diet. If the child or even pregnant women, if they don't have enough iodine intake during the pregnancy or during their childhood, they may experience this mental retardation. So please take note of the condition called cretinism, which affects children born of mothers who were not able to take enough iodine during their pregnancy. Right, so people with hypothyroidism would have slow metabolism, leading to like they are fat compared to hyperthyroid, so they are rather skinny. All right, so what else? Some people may experience mixed edema, MYX edema. So there is moon phases, so their face is like the full moon, rounded. Okay, and there is edema, so that means that there is liquid in the subcutaneous tissue. So this condition can also be caused by secondary mechanisms like pituitary involvement when there is a problem in the release of TSH, so that can be secondary hypothyroidism. Right, so this can also be one cause of goiter, so the enlargement of the thyroid gland. So the reason why the thyroid gland gets enlarged in goiter, it is because there is not enough iodine to process or to produce T3 and T4. So the thyroid gland is trying to um, hypertrophy. So that means it becomes bigger in size. The cells become, numerous, leading to goiter. Right, so how do we measure the hormones? So it's possible to do RIA, we already talked about this, chemiluminescent assay, or FPIA, or fluorescence polarization immunoassay. The most common methods would be chemiluminescence assay and radioimmunoassay. For is the specimen, we can use serum or plasma. If it's plasma, we can utilize heparin or EDTA, and we can also utilize whole blood depending on the procedure. Right, so quality control, we talked about quality control all the time, but we will devote one meeting just for quality control. But for this purpose, I just want to mention that there are those rules that we can follow in order to accept or reject the run during a quality control analysis. This is done daily. Validation of the patient's result is necessary. So you have to compare, make sure that the result is intended is for the person, okay, the right patient. Right, so sources of error, of course, if we use the wrong specimen, for example, if it's hemolyzed, that can lead to false results, wrong anticoagulant, even lipemic specimens. So therefore, it is advisable that we utilize fasting sample to avoid lipemia and exposure to heat or sunlight. So we have to protect this specimen from heat or sunlight by covering it with, say, carbon paper or aluminum foil. Okay, and another possible source of error may be related to the instrument itself. So we have here the normal range for T4. Of course, the value may be different depending on the method and the country. Right. So anyway, so this is just for purpose of being familiar with the amount and the reference range. So the T4 level is about 5.1 to 11. That is 66 to 142 nanomoles per liter. And look at the difference between T3 and T4 level. So T3 is much higher. There is more T3 compared to T4. Right, and there is what we call free T4, so that means this is not attached to a carrier protein, thyroxine binding globulin, or albumin. So those are the two proteins that can carry T4. The range may be method dependent, as I mentioned, and it can be adjusted per age. So this is dependent on the laboratory. The patient's results should be compared with the reference range for appropriate interpretation. Right, so additional testing may be necessary to make a diagnosis of thyroid diseases in newborns, as I mentioned. That is cretinism, which is very important because this may lead to abnormalities, especially mental retardation. So the development of the mental capability has something to do with the thyroid hormones. So these are the different tests like neonatal screening, okay, newborn screening. TSH levels can be measured, free T3, reverse T3, and TBG levels. And of course, also for autoimmunity, as I have mentioned, there are diseases, for example, exophthalmic goiter or Hashimoto's disease. Those are examples of autoimmune disorders that affect the thyroid gland. Right, so again, this is being emphasized to avoid false analytic errors. Make sure that the right patient is indicated in the result form, okay, and the right reference range and the very timely release of the result. Otherwise, it would not be very useful. Okay, so thyroid problem is rather common, but for example, in the case of goiter, this is usually endemic, so that means it is found in locations where there is no access to iodine. Right, so the issue is how to make this iodine accessible. Right, so we know of the iodine in iodized salt, so that is the most common source of iodine. Right, so in mountainous areas, you may find, for example, in Baguio, you may find some people with goiter. It's also because of the diet. There are some substances that contain anti-thyroid agents, which is present in vegetables like cabbage, the green leafy vegetables. So it's usually not suggested to, if you have thyroid problems, especially hyperthyroidism, it's not suggested that you eat those kinds of vegetables. So that is the last slide. This is the question. Right, so anyway, so try to answer the last question in your VLE, sources of error in thyroxine analysis. Thank you.